Next, I'm delighted to present another dynamic duo. We have both Esther Freeman and Dr. Doriane Sabushimike. Oh my gosh, I need some water. Who are going to be presenting to us on the Mpox outbreak. Esther also is someone who probably needs no introduction in this audience, but she is soon to be the endowed chair in global health dermatology at Mass General, which is being funded from L'Oreal and CeraVe. So that's a really huge honor and accolade to have there. And she's the founding and immediate past chair of GLODERM, and she's been really, really instrumental not only in the global dermatology realm and connecting in the mentorship program, but also in studying outbreaks, which is her area of research interest. And then Doriane is an amazing individual as well. She's one of our graduates from the GLODERM mentorship program. She's currently one of the consulting dermatologists who's really leading in that area in Burundi, where she has an interest in persons with albinism, living with albinism, and has also been really a dynamic leader in increasing access to dermatology care. In her role at Burundi, she has really become the leader in Mpox and the outbreaks and has really been navigating a lot of that and have really bringing dermatology to the forefront of the importance that we have. So I'm delighted to present Esther in person and Doriane virtually. So thank you so much.
Thank you. And I just have to say, this is like my favorite part of AAD. I feel like when it hits like 12:30 p.m. on Thursday, I'm like, I'm done. I saw everyone I wanted to see. This is fabulous. Seeing this group of people really feels like a family reunion. And I'm just so honored that everyone, kind of continues to grow this family, and just the roots that everyone has in different parts of the world. It's just really inspirational. And this is off piste. I might get in trouble with Carrie because I know we're already running late, but two things. One, this week really, I was reminded of a memory about this group, which is that GLODERM had its very first scientific meeting at AAD only 6 years ago. And this like popped up on my social media this week. And I was like, 6 years ago, like a lot has happened in 6 years. We're over 2,000 members. We're now in 90 different countries. And it's just incredible to me that this has really kind of snowballed over the past 6 years. So I just want to take a moment and just recognize all of you, because many of our co-founders are in this room, and this has always been such a massive team effort that everyone has contributed so much to. So I just wanted to say thank you for the journey. It's been, just really incredible. So with that, I'm going to chat about Mpox, and I'm really going to just set up the stage for Dr. Doriane Sabushimike, who is joining us through video from the front lines of the Mpox outbreak in Burundi. And she's unfortunately not able to be at the AAD this year. So I wanted to kind of set the stage for her, and then she'll take over. These are my disclosures. So just to remind us where we are with Mpox, because I'm actually curious, how many people feel like they have active Mpox outbreak or cases in their community? Show of hands. Okay, so like a fair amount scattered around the room. Okay, so people are seeing Mpox. I see some of our colleagues from Rwanda, some of our colleagues from the US, from a variety of different places are seeing Mpox. So just to kind of remind all of us, the global outbreak of Mpox, the newest outbreak, began in 2022. And I want to be clear that this is already previously endemic in many countries in sub-Saharan Africa, right? So it's not like Mpox just emerged in 2022, but it became truly a global outbreak in 2022 and was declared to be a WHO worldwide emergency. This was really mostly clade 2 of Mpox, and it spread across the world, with most cases occurring in men who have sex with men, higher risk groups, but also importantly occurring in 98% of the countries affected by this outbreak were previously countries where Mpox was not endemic. So these were new countries where it was really spreading rapidly throughout the world. And then we did see this slowing of transmission. There's also a natural epidemic curve. We also had increased vaccination, for example, in the US of high risk groups. But I want to be clear, complete lack of vaccination available in most parts of Africa, even to this day. And so there was an end declared to this emergency. Now, the end of the public health emergency lasted not very many months, because then in 2024, there were multiple new outbreaks of Mpox, and now different clades. So clade 1A, 1B, and 2. And this meant that the WHO, within a very short time span, again declared this to be a global public health emergency worldwide. So just within 2 years, kind of 2 global emergencies related to Mpox. And there continues to be a surge. And I wanted to just kind of put this in context of where we are right now. So if we just look really in the past year, There's been a huge outbreak in the Democratic Republic of Congo and neighboring African countries. So Burundi, where Doriane hails from, is right next to the DRC and shares a border. And they've reported over 50,000 suspected clade 1 Mpox cases and over 1,000 suspected deaths. This is likely a significant underestimate of what's going on. But you can see from the map that we really have a variety of clades. The different colors are just showing you that there are different clades involved spreading across the area. And you can really see that the cases are picking up in the DRC and surrounding countries, and that we are likely to see these effects truly worldwide. So outside of Africa, in the newer outbreak here in 2024 and into 2025, we've seen at least 13 different countries that have reported detecting clade 1b cases. And so just to point out, there's different clades of Mpox. Clade 2 was the big one that we saw in 2022, not as severe. Less hospitalization, less death, whereas clade 1b is potentially higher risk, particularly for our patients living with HIV, potentially higher risk of hospitalization, higher risk of death. So this is a kind of a more severe strain. What I want to point out for most of the world is that you see that it's like this stripy, vibrant color. You don't need to be able to see the very specific colors, but the stripiness means that this is a mix of strains. So some clade 1, some clade 2, right? So for example, where we are here in North America, we are seeing mixes of both clades. Now, I don't think we have a lot of data on how different the clinical lesions might be in clade 1 versus clade 2. In theory, if the lesions read the textbook, they are supposed to go from vesicle to pustule. Actually, I see Kieran in the back. There's Kieran. So Kieran is deeply involved in the WHO categorization of how we describe Mpox lesions. And Kieran calls these pseudopustular donuts. Is that your pseudopustular donut, Kieran, in the lower left there? So hopefully meets Kieran level approval. If anyone has any clinical questions about Mpox, please go chat. I'm throwing you under the bus, Kieran. Go chat with Kieran afterward. You can wave your hand. He's like, no, there he is. Okay, great Mpox clinical expert for anyone who needs to consult on a case. So you can see they kind of go through this stage, and then this is the pseudopustular donut. We had a whole long discussion of whether the word donut translated multiculturally, and we decided it did not. But if you're American, then you can appreciate the donut. And then eventually goes into a scab and into crusting. So with that, I wanted to pass it over to Doriane, and hopefully we'll be able to figure out the sound, who's going to share her expertise from the experience frontline in Burundi. I'm going to go back and then restart that slide just so you guys can hear her. All right, so let's see our wonderful AV crew here. All right, am I okay to go forward, Becca? With that, I would love to introduce the lovely Dr. Doriane Sabushimike, who is really dealing with the front line of the Mpox outbreak in Burundi as she's seeing patients come across from DRC in the neighboring country. And we're so proud of Dr. Sabushimike. She was in our original cohort, class 1 of mentees. She's someone who left Burundi to go train in Rwanda for medical school and then Tanzania for residency, and is now returned back to be the 6th ever dermatologist in Burundi. So she's kind of living, breathing a proof of just these extraordinarily inspirational people that we're so lucky to be connected with in GLODERM. And with that, I'm going to see if this works. All right, I got the thumbs up.
Hi, my name is Doriane Sabushimike. I'm a consultant dermatologist from Burundi and one of the GLODERM mentees, cohort number 1. And it's a pleasure to talk about our experience at the Kamenge Military Hospital with the Mpox outbreak. So I'll start with a brief synopsis about the situation of Mpox in Burundi. In total, by December 31st, we had a total of cases of 2,975 cases. And most of the cases were found in Bujumbura, the economic capital city, and Gitega, the political capital city. And it is I thought that it may be because of the frequent cross-border movement between the two cities and the RC. So now coming to the Kamenge Military Hospitals, by January, we had treated 291 cases, and the majority were aged between 18 and 40 years old. Few were above 40. So our first case was in July 22nd, July for last year. And just after it has been confirmed by the national lab, we set up an isolation of 28 beds. And by September, November is where we had most of the cases. And currently, we have very few cases. Like now, we have only 7 cases. the isolation. Mainly, they present with generalized umbilicated papules and vesicles that ulcerate and leave hyperpigmentation, can affect any part of the body. For kids who are generally less affected and who stays even in the hospital for a few days compared to adults, are most of the time not very much affected, but we have sometimes cases like this one that is that you are seeing now with generalized papules and vesicles that are umbilicated, associated sometimes with fevers and myalgia. So we noticed that most of our cases were having genital manifestations. And for those who are aged above 18, almost 100%. And most of the time they present like this, vulvar ulcers and edema in female patients that evolve well after being treated with topical management. And most of the time we give permanganate potassium and topical antibiotics. And ulcers, we also apply a zinc oxide 20%. They heal very well. These are other cases that we have received. But sometimes we have those who develop a deeper ulcers and they stay in the hospital for a longer period, because generally they stay for 2 weeks, but they can go up to 1 or 2 months when there are such ulcers. For male, same manifestation, papules that ulcerate, sometimes associated with very painful and fluctuant adenopathies. In that case, we have to give systemic antibiotics. So we had only 2 cases of male with anal lesions, and it was unfortunate that we couldn't confirm if they had sex with other men, as it is something prohibited in the country. So another case that was very important for me to share is a case that we're also publishing, where we had Mpox with HIV. Was a lady who was brought in emergency after 1 week of fevers and body weakness genitalia. So I was the one who confirmed, who suspected the Mpox, and it was confirmed by the lab. I will not go through all investigation that she had, and management was mainly symptomatic, and we didn't start IRVs until she got better. So she developed necrotized ulcers that were full smelling with flies that were coming on it, but that healed well with vinegar soaking and topical antibiotics. So this is how she looked 1 month after being discharged and being on IRVs. So management that we provide is mainly symptomatic, that we got from the protocol, the national protocol that I had the honor to be one of those who established it. And we have an isolation, and thanks to WHO office in Burundi who helped us those tents. So as I said, we give symptomatic management, as we don't have antiviral and the vaccine. So I will acknowledge the Mpox team that have been working with since July last year, the leadership of the hospital, and thanks to Prof. Wende and Prof. Esther Freeman, who has been with me during this outbreak.
On behalf of both Doriane and myself, I just want to also say a huge thank you to our research fellows who were, many of them were checking you in. So Chrissy and Sarah, I think you were not here when we acknowledged you earlier, so you can wave our wonderful check-in team in the back. And so thank you all, and a special huge thank you to Carrie for all of her wonderful organization.